Hello and welcome to Day Habilitation and Sobering Centers in Orange County, all part of our new CalAIM Community Supports Early Adopter Series made possible by the California Healthcare Foundation. Next slide. So if you have a question throughout the session, there will be a facilitated Q&A. So please feel free to click that link Q&A at the bottom of your screen and submit a question. Next slide. Some about our agenda today. We'll start with some welcome and introduction, some level setting to make sure that everyone on the line from California and our national stakeholders on the line are aware of what these services are, what the policy context is, and specifically, what does implementation look like for these particular services? For awareness, and you will hear this several times today, sobering centers and day habilitation services are optional managed care services. In many state contexts, these are called in lieu of services. And CalOptima Health in Orange County is one of the few Medicaid managed care plans that have actually opted to provide these services. And so we'll be unpacking what implementation looks like from CalOptima Health's perspective, as well as their two community supports providers, Be Well and Chrysalis. Next slide. So some introductions. If you are new to the Center for Healthcare Strategies, first of all, welcome. We are a policy and implementation partner dedicated almost exclusively to Medicaid. We do a lot of what you will see here today, elevating those best practices from different pockets of the country and saying what that might mean for stakeholders in a particular state, as well as stakeholders nationally. Next slide. So my name is Diana Crumley. I'm Associate Director of Delivery System Reform at the Center for Healthcare Strategies. A lot of my portfolio has been tracking initiatives relating to Medicaid managed care, primary care, and health-related social needs as well. And this is very much a partnership with our partners at the California Healthcare Foundation. You will see two program officers from the California Healthcare Foundation facilitating some of that discussion, bringing those rich implementation insights that they've been elevating through their portfolio, as well as their past implementation experience. That's Mariana Torres from the California Healthcare Foundation, as well as Melora Simon. You will also hear from CalOptima Health, Mia Arias, Director of Medi-Cal, CalAIM, and CalOptima Health, and also Nicole Ramirez, Director of Quality Improvement at Be Well, and Mark Loringer from the President and CEO of Chrysalis. So very much excited for our presentation today. And with that, I will turn it over to Melora.
Thanks so much, Diana. It's great to be here. I'm Melora Simon, an Associate Director on the Advancing People-Centered Care team here at the California Healthcare Foundation, focused on people with complex needs. I wanted to spend just a few minutes setting the context for this series. As many of you know, California is in the midst of a transformation of its Medicaid program, one component of which is CalAIM. CalAIM includes many reforms and programs, some of which are focused on people with complex needs. Two that are well underway are enhanced care management, which is a new benefit that offers care coordination and navigation for 9 specific high-need populations of focus. And the other is community supports, which are 14 pre-approved, non-traditional services that managed care plans can offer to address health-related social needs. Unlike enhanced care management, community supports are optional, and we see tremendous variation in their offering and uptake. While some, like housing navigation and medically tailored meals, have been widely adopted, others had almost no utilization at all in the first year of the program, 2022. However, we're lucky enough that some of these less utilized services are being used in some places at scale. So if we can move to the next slide. This series is about going deeper into those regions to delve into the partnerships that are at the heart of the provision of those less utilized community supports. And in doing so, to really understand the motivations and implementation choices so that others seeking to offer them or to optimize their operationalization can really learn from those experiences. So today we're heading to Orange County to hear about their partnerships to offer sobering center services and day habilitation services. If we move to the next slide, we also just briefly want to let you know that we have a resource center that's dedicated to CalAIM implementers. It's where we kind of keep our collection of resources on CalAIM if folks have additional questions. But without further ado, let me turn it over to Mia from CalOptima Health, who will start with the plan's motivation to offer these services and how they got started. Thanks very much.
Thank you so much, Melora. And good morning, everybody. It's such a pleasure to be here today to talk a little bit about CalOptima Health's strategy in terms of implementing CalAIM, specifically focusing on day habilitation and sobering center services. My name is Mia Arias. I am the Director of CalAIM Operations here at CalOptima Health. I've been here for about a year and a half and was hired specifically to help to run the operations of CalAIM services here at CalOptima. Next slide, please. So just to ground everybody and a little bit of information about who we are, CalOptima Health is a managed care plan here in Orange County. Our mission is to serve member health with excellence and dignity, respecting the value and needs of each person. And this mission really does set the stage for how we as a plan have decided to implement all of our CalAIM services. We were founded as Orange County's community health plan for low-income families, seniors, and people with disabilities. We do serve 1 in 4 adults and 1 in 3 children in Orange County. So our footprint in Orange County is quite large and expansive. I think it's always interesting. People have a perspective of Orange County. You think about the housewives of Orange County, you think that it's a very wealthy county. Well, there is a lot of wealth here in Orange County, but there's also a lot of poverty. And so we at CalOptima Health do have the opportunity to serve many, many members across our county. We have 1,500 employees and an annual budget of $4 billion. Next slide, please. So again, kind of riffing off of Melora's introduction of CalAIM and talking a little bit more specifically about the goals, because a lot of the goals that DHCS set out for CalAIM were goals that we really wanted to ensure that we were setting at the forefront of implementation for CalAIM services here at CalOptima Health. So CalAIM is really trying to innovate Medi-Cal and services for our members. We're looking at addressing California's physical and mental health needs, really looking at person-centered care and understanding that individuals have very many complex factors that influence their health. CalAIM is looking to improve and integrate care for all of our members and for all Californians across the state who are getting Medi-Cal services. We're really looking at this initiative as being a catalyst for equity and justice. I think health equity is absolutely one of the primary values that we're looking at as a plan when we're implementing CalAIM services, and really across the state working together to build a healthier California. Next slide, please. CalAIM's initiatives. I know a lot of time when we think about CalAIM, we're really talking about the community supports and enhanced care management, but really CalAIM spans across several different initiatives that touch our members' lives. We're looking at behavioral health, dental health, incentive payment program, funding dollars to support various programs in our community, homeless and housing incentive programs, integrated care for our dual eligible members, focusing a lot on services for our justice involved members. There's a lot we're also doing in the field of population health management. Next slide, please. We're also integrating statewide changes to manage long-term care, supporting health and creating a lot of new opportunities for our children and families. And of course, the two big initiatives that we're focusing on and talking about today, community supports, and enhanced care management. Next slide, please. So I wanted to spend a little bit of time talking about our approach to implementing CalAIM as a whole, because I think a lot of these ideas really carry over into how we specifically thought about implementing both day habilitation and sobering center services. So as DHCS really laid out the framework for CalAIM, we really wanted to be very community-based and thoughtful about bringing in organizations who are working with our members. When we started here when our small team started here at CalOptima Health and started thinking about the organizations that we wanted to partner with and to contract with, we'd heard that CalAIM historically has partnered with just a few organizations, like the biggies in Orange County. And we wanted to really think about that and really flip it on its head and look into the community, have conversations with our members, but also with various stakeholders, and think about how we can go beyond partnering with the biggies, as we would call them, and looking at partnering with other smaller community-based organizations who have really worked for many years with specific and very niche populations of focus that are now going to be eligible for a lot of the CalAIM services that we're providing. We wanted to build meaningful partnerships with these organizations and with our partners. And that meant, again, having multiple conversations, talking and really learning about the services that the CBOs and different nonprofits and community health centers provide in Orange County, and talking about how those services actually fit into the CalAIM framework, and how a lot of what they're already doing are services that we are now going to be providing and funding through the CalAIM initiatives. Part of what we talk a lot about, especially early on when we were launching all of the services for CalAIM, is that we were really building the plane as we were flying it. We were trying to contract with organizations while at the same time understanding what the policy guidelines were and perhaps tweaking those guidelines for us. So ensuring that our partners understood that we're going to set some things up and they might fail at first, but we're really interested in working and learning together so that we can evolve what we're doing to make sure that what we're doing is successful and at the end of the day, benefiting our members. The other thing that I want to focus on is that we are as a health plan, CalOptima Health is very dedicated to providing ongoing support to our partner organizations to really make sure that at the end of the day, the benefits and the services that we're rolling out are the highest quality services for our members. We created internally what we call a liaison position, which is dedicated to working directly with all of our contracted community supports providers. They meet with them at the beginning of our partnership on a weekly basis. Now, for the most part, they're probably meeting with our partners on a monthly basis, but really that conversation that the liaisons are having with our providers is focusing on any trouble that they're having, really focusing on helping them to potentially reach out to new members, troubleshooting. I think a lot of the time when our new organizations were contracting, there were a lot of issues with billing, so making sure we could resolve those. We know that a lot of our organizations, because they're smaller, and have smaller budgets, cash flow could be an issue for a lot of the organizations we're partnering with. So making sure issues, again, like billing are resolved quickly and that they didn't have to navigate several departments within CalOptima Health to get their answers quickly, to get their questions answered quickly. So creating that liaison position was incredibly important for us. We're also providing ongoing training for all of our CalAIM supports providers, whether that's for community supports or for ECM. We've created what we call the ECM Academy. So throughout the year, we'll be offering monthly opportunities for training for all of our partner organizations to tap into so that they can continue to learn how to provide the best quality of services to our members. Next slide, please. So now talking a little bit specifically about day habilitation. So just to kind of level set, this service was designed to assist for our members in acquiring, retaining, and improving self-help, socialization, and adaptive skills necessary to reside successfully in one's natural environment. Now, I pulled that directly from DHCS's policy guide. I think we always kind of thought that one's natural environment was an interesting wording or interesting language, but how we interpret that is hopefully to help somebody to reside in a home. Some examples of what this service might look like is support to learn how to use public transportation, personal skill development and building, how to help individuals do simple daily living skills at home. We also talk about things like how to help an individual budget so that they can make their rent on a monthly basis. This service can be provided in a group or individual setting. The length of service is really as long as necessary based on the needs of the individual member. We authorize this service in 6-month increments or authorization periods. Next slide, please. In terms of eligibility criteria, members have to be either homeless or at risk of homelessness or institutionalization, or have recently left homelessness and have recently entered housing within the past 24 months. Next slide, please. In terms of our numbers or our stats, we are currently contracted with 11 different providers across the county. Later on, you will hear from Mark, who is the CEO of Chrysalis, one of our contracted partners. A lot of these organizations are CBOs. We do have a couple of recuperative care providers and shelters who are also contracted to provide this service. Since the launch of the service, which was in July of 2022, we have served 732 members with day habilitation, and we are looking to improve that number within the next year, as well as to contract out with a couple of more providers who will be offering the service to our members. Next slide, please. In terms of sobering centers, just a little bit of context. The service provided by sobering centers includes medical triage, lab testing, really a temporary bed and rehydration and food services. I think that's probably the core of the sobering center service. They can offer treatment for nausea, wound and dressing changes, shower and laundry facilities, substance use education and counseling, navigation and warm handoffs for additional substance use services or other necessary healthcare services, and homeless care support services upon request. The length of service for this particular community support is 24 hours or less. Next slide, please. In terms of eligibility criteria for individuals or members to utilize this sobering center service, they do need to be adults, 18 and over. They need to be intoxicated, obviously, conscious and cooperative, able to walk, non-violent, of course, free from any medical distress, including life-threatening withdrawal symptoms or apparent underlying symptoms, and agreeable to obtain services. Next slide, please. For our sobering center, we are currently contracted with 2 providers in the county, one of which is Be Well, who you will hear from shortly. And from the since the launch of this service, also in July of 2022, we have served 705 members with this service. So that includes my brief presentation. I think from our perspective at CalOptima Health, we're very excited for you to hear from 2 of our providers. I think they are best able to really speak to the partnership that we have worked to develop with them and really speak to the services that they are providing to the very important service that they're providing to our members through the CalAIM initiative. Thank you. Now I'm going to go ahead and hand it over to Nicole Ramirez, who's going to be talking about Be Well and their sobering center.
Thank you, Mia. Good morning or good afternoon, everyone, depending on where you're attending from. I'm happy to be here to represent Be Well OC and the partnership that we have with CalOptima Health. Be Well Campus started as an investment of multiple partners in Orange County, including CalOptima Health, to address the mental health and substance use service needs of OC residents. Our campus provides a continuum of care services. Next slide. And as you see in the photo, these are some of the services that we're currently providing on campus in Orange County. This includes the Sobering Center as a voluntary service. And the Sobering Center currently operates with 12 beds and provides a 24-hour or less service for residents to get sober in lieu of jails, hospital EDs, or other inappropriate places of care. And it enables the client to be assessed for additional services they may need, which they then can transition into here at the campus if needed. Next slide. So this is some of the criteria for a client to receive services at the SoBrain Center. As mentioned earlier, this is a voluntary service. So everybody who receives services here is on a voluntary basis. That next level of care, if they should need it, could be determined whether it is voluntary or involuntary, depending on, like I said, the service needed. And typically we can transition people into other services here on campus, which makes this a great opportunity for some continuum of care services. Currently, the SoBrain Center, it operates the 12 beds, and as I mentioned, we are triaging people away from being hospitalized, attending hospital EDs who typically would service the client, but it's not an appropriate level of care. And through CalAIM Community Supports, we were able to partnership with CalOptima Health through a grant. And that enabled us to enhance our SoBrain Center services by hiring care navigators. Next slide. This is just a photo of the SoBrain Center. We call them beds, but essentially they're cots. It is designed to ensure safety of the client and to provide a little bit of privacy, but also to ensure that the clients are viewed, 24 hours to ensure that they are safe and in a secure place to sober up, essentially. The opportunity of partnership with CalOptima Health was really an opportunity for us, as mentioned, to hire on care navigators who are able to connect with the clients upon intake. This ensures that the client receives the care and supports they need. The care navigators partnership allows the client to be assessed for other social services, social supports that they may need. And it includes partnership with our housing coordinators and other local entities in Orange County. We really saw this as an opportunity to address some of the unintended gaps in care that clients face, particularly with respect to the fact that if they are entering the SoBrain Center, they are under the influence, and a lot of times that ineligibilizes them for other services at that moment. So we see this as an opportunity to provide that space for them to get into a state of ability to be assessed, and then to be able to hopefully transition them into that next level of care or out back into the community where they can receive other supportive services. During the first half of 2023, we saw 760 clients at the SoBrain Center alone. That was about an average of 8 persons per day. And of those clients, 381 came to us by self-referral, which is a big number. Additionally, we had 87 referrals from law enforcement. They're one of our biggest partners here in Orange County, and they see this as a resource for them to be able to bring clients to the care they need and keep them out of jails or utilizing resources that shouldn't be used for that particular service. Through the other way that clients came into the center were through our Be Well mobile. Those are vans that also bring the client in voluntarily, and we saw 175 clients come in through that resource. The majority of the clients were CalOptima members. Of that 760 clients that received care in the first half of 2023, 599 were CalOptima members. So we truly saw this as an essential partnership in the Orange County area, being a natural progression as CalOptima serves all of our Medi-Cal and Medi-Medi members. And through the partnership of CalOptima and the community supports effort, our care navigators were able to connect 539 clients to resources and referrals at discharge. That really highlights the success of our engagement in the SoBrain Center services and our partnership with CalOptima Health. I'd like to conclude my presentation for the moment. As they mentioned, we will have Q&As after, but I'll turn it over to our moderator.
Thank you, Nicole and Mia. I see there's some great questions coming in on the chat, and we'll ask a few higher level questions, and then we'll have a chance to dig into some of those questions on the chat. So I just want to acknowledge that I'm new to California Healthcare Foundation, and early in my career, I worked as a behavioral health provider in the 5th largest jail in the United States in Alameda County. And it surprised me how many people were struggling with the negative impacts of alcohol use that didn't really belong in jail. So I really appreciate about CalAIM and hearing you speak that it brings stakeholders to the table to work on building out a continuum of care and providing the level of services that meet an individual's needs. The first question is for Mia. What advice would you have for managed care plans or providers thinking about building out a sobering center in their community?
Yeah, great question. And I think Nicole can probably also jump in and help me answer this. I think from an MCP's perspective, it's really finding the correct or the right fit in terms of a service provider. Like I said, partnerships and trust and having ongoing conversations is really the critical piece, I think, at making these relationships successful. And when we talk about bringing down any kind of new service provision, we really think about creating win-win-wins. So a win for us at CalOptima Health, a win for the organization that we're partnering with, and ultimately really a win for our members. And so for sobering centers, I think here in Orange County, we were lucky enough to already have Be Well in our backyard. We already had an established relationship with the organization. Our leadership here at CalOptima Health has worked really closely with the leadership at Be Well to build that service and that center and all of the other sort of ancillary services that are connected to Be Well. So I think we were in a bit of a unique position. I think in other counties, it's about finding those providers who, if they don't have a sobering center operating yet, somebody who's at that level of readiness to expand and to bring in this new service into their county. Nicole, I don't know if you want to add anything on to that.
No, I agree with Mia. You know, the opportunity of having the sobering center already operating was, was there. So we also had the partnership with CalOptima. They were one of the partners who helped to fund the Be Well campus in Orange. And just knowing that the service was needed and that we were able to enhance our partnerships with other community providers. For example, I mentioned the law enforcement and being able to bring clients into the appropriate level of care at that time of need. Just the partnership with CalOptima allowed us to enhance those services by providing that extra niche of having the care navigators who have been very instrumental in helping to guide the client through that next level in their journey of care, whether it be out back into the community or into another service that is available to them.
Thank you, Nicole. Can you talk a little bit more who are the key partners and the referring agencies that bring people to the sobering center?
Certainly I can. So we currently, I mentioned during the presentation that we have a lot of self-referrals that's really getting the word out. We are constantly out in the community outreaching to our hospital networks. Our hospitals are a referral source. We remind them all the time that we're here, we're available. I think by nature of the service and then also the client's presentation. So because it's a short-term service, a lot of times if they are already at the hospital, they've already been assessed, so they're not an ideal candidate to come then to the sobering center. But our law enforcement is a huge partner in bringing referrals into the campus. They're out in the community, they see somebody in need and they're able to bring them here as opposed to taking them into jail, as you mentioned, which are filled with people who shouldn't be there, in need of mental health services or sobering center services. So that's been one of our key partners. Outside of that, really anybody can refer in there. It's not a closed referral system. Anybody who is in Orange County operating in the service space can send somebody into our services, shelters, community providers, anybody who thinks that someone is in need of sobering can refer in.
Thank you, Nicole. And the next one is for Mia. I'm going to take one off of the Q&A because we had a similar question. But just basically, are you able to bill Medi-Cal for sobering center stays? So just kind of level setting where we are here in California.
Yeah, so that's one of the new, obviously as a new community support, Be Well or our other provider is billing directly for each of the stays that our members utilize. And that's a per member rate per member per stay.
Thank you. Let's see. What if someone I'll go back to Nicole. What if someone does come through the door and doesn't have Medi-Cal? How do you interact with that visit?
Yeah, so the Be Well campus was designed so that anybody can receive services regardless of whether they have insurance or not, or the ability to pay. So depending on the client's need and their payer status. So if they have zero, no insurance, they don't have Medi-Cal, we can determine if they're able to apply for Medi-Cal. Our care navigators can help facilitate that so that they're able to apply for Medi-Cal. Self-pay is an option. Obviously, if someone doesn't have funding, that would be at a very reduced rate. So we have the opportunity to do that. And then we also have contracts with insurance companies. However, Sobering Center is not technically a covered service with some insurance companies, but we do, for example, have a contract with Kaiser where if somebody lands in a Sobering Center and they have Kaiser, we can also divert that billing to Kaiser, and we have a contract with them at a reduced rate so that the client is able to receive those services.
Do you enroll people in Medi-Cal if they're not enrolled, or is that not part of the scope of services?
It's not part of the scope of our service, but we do connect them with someone who is able to help enroll them. Currently, we're not at that level, but we do see that as an essential. I think for the most part, we have great partnerships where we're able to connect them right away to get that document ready.
And are you leveraging this is from the kind of Q&A from the audience, are you leveraging other funding to ensure financial sustainability beyond the kind of rate that you get from CalOptima?
Well, as I mentioned, we do have contracts with insurance payers, and we also, Be Well is also operating off of philanthropic dollars as well. So, we're unique in the position that we have been able to pull together different funding resources.
But the kind of on a per client basis, does the MCP rate cover your costs for MCP clients?
Yes, the Sobering Center services we have a direct contract with CalOptima as well as other payers, and so that enables us to have those services covered fully.
Thank you, Nicole. And I also want to acknowledge, it was one of the first questions coming in. A lot of times sobering is for alcohol, but are you also doing drug sobering?
Yes, we do. A number of our clients are coming in with multi-drug use, so they might have combined drug use that they're coming in to sober up from.
Thank you. Let's see how, let's go back to Mia. How do you envision Be Well and sobering centers working with the other community supports providers?
Yeah, that's a great question. We actually really take an opportunity on a monthly basis. We have what we call all provider meetings. And one of the functions of those meetings is really to have all of our different community supports providers have an opportunity to talk about their service and really market their service to the other providers that are contracted with us. So for Be Well, and because Orange County is relatively small, most of our partner organizations are aware of Be Well and the services they provide. So making sure that they're able to utilize those for the members that they're seeing, or for individuals who may not be members within their sites, within their facilities, who are their clients, that's a really important factor. And again, that goes beyond just sobering. I think that's for all of our different services, whether that is medically tailored meals or whether it's respite. We know that the individuals that they see are at that point in time like a captive audience. So being able to make referrals to everything that they can at that point of contact is incredibly important, and we want them to utilize that time. So making sure again that they're aware of all the services that are now covered through CalAIM is really important and is an ongoing effort by us as the MCP.
Thank you. And can you touch a little bit? When I first started my journey in CalAIM, I'd come across sometimes health plans like we're only here to authorize or deny. So can you talk a little bit about the authorization procedure and how that's either changed or how you've leaned into it or think about it when you deal with CalAIM?
Yeah, for us, actually, the way that we've structured sort of the operations of all of our CalAIM services. So I am on a very small CalAIM team here at CalOptima Health. We then partner with our LTSS team, who actually is responsible for all of the authorization procedures for all of our CalAIM services. So we work very closely with that clinical team to ensure the authorization process for each of our community supports looks a little bit different. So we work with them to make sure that things are running smoothly. Again, as I mentioned earlier, we are still really evolving these services as we learn more about what's working, what's not, what we're seeing in terms of barriers to utilizing some of these services for our members. We're working together to see how we can lessen some of those, how we can maybe tweak our own policy guidelines to make sure it's clear to our providers what the workflows are, and if we're changing something, what that change means and what that entails. So it is a very close collaborative effort. But we're definitely, obviously, I'm hoping, as you've heard, we're not just here to authorize or deny. We're really here to set the foundation for ensuring that all of these supports are successful. And that means a lot more than just playing that function.
Thank you so much. I'll turn it back over to Melora, Diana, to see if there was so many fabulous questions. I scanned a few of them, but I'm hoping somebody else was taking a look and was picking up the juicy ones.
Yeah, we and for awareness in the California context, there's non-binding pricing guidance, and I believe CalOptima Health did something interesting when it thought about community supports implementation. I'm wondering if Mia, you would like to talk about that. You know, where in the rate guidance, how is the rate guidance a tool for you, and what did you do for implementation?
Yeah, and really, I can speak to that sort of in general, but I'll also give a little bit of context. So our small but mighty team, again, that was hired to implement all the CalAIM services, we actually, for the most part, all come from the provider world. So we were hired sort of, and I've mentioned this, I think, in several different contexts, but we are kind of unicorns in this world. We don't have an MCP background. This is not something that we've done before, but we were hired by our leadership, and we always give kudos to our leader, Michael Hunt, for bringing us in, because we really thought about implementing all of these services from the provider perspective. And for us, when we were looking at the pricing guidance, we used that, but we also wanted to have those conversations that we were having with those providers sort of weigh into how we decided to structure the pricing and the reimbursement rates. So I would like to say that for the most part, we are taking either the highest suggested price point for reimbursement or even going higher depending on the specific services. You know, some of the questions that I saw, or at least one of the questions that I saw coming through the Q&A is how do you make yourself whole? And I think we're very cognizant of that fact that for some of these services, you're going to have to look at braiding in other funding sources. But at the end of the day, because we're dedicated to what we've dedicated ourselves to launching all of the 14 community supports, we want to see those be successful and we want to see them be sustainable. And in order for them to be sustainable for these providers, we need to be able to provide them the funding to do that. And so that was incredibly important to us. And I think, again, as we continue to learn from our providers where their gaps may be in terms of financing, we'll continue to sort of adjust. The other thing I did not mention, but we did also offer capacity building in the terms of an IPP funding for all of our community supports providers. So we gave them essentially all they had to do is fill out a pretty simple application, $100,000 to help to start and launch their services.
I have a follow-up question on that. I remember from our pre-call that collectively you went from like not offering the service at all in Orange County to kind of standing it up relatively quickly. I'm not sure if this is a question for Mia or for Nicole, but can you talk a little bit about that journey and kind of how you work together to stand it up so quickly?
Yeah, I think
Go ahead, Nicole.
from BeWell's perspective, so the Sobering Center was already open and operationalized for I believe about 6 months, and then the community supports aspect came into play. And so we were tracking CalAIM for several years before it was even a thing. And so we were really gearing up to ensure that the services that we were providing also aligned with the mission of CalAIM. So having the Sobering Center open and then having that opportunity of the community supports open up to us allowed that quick transition to be able to continue to provide the services to the community, but to cushion that the funding piece of it by allowing more residents to receive that care and to be able to then fund it with Medi-Cal dollars, right? So that allowed us to then, as I mentioned in the presentation, enhance those services by providing the care navigators. So as Sobering Centers first opened up, we didn't have the care navigation team, and the care navigators really serve as that linkage component for that client, whether it's as they're coming in and just determining what is it that they're lacking or that they need that we can help fill that gap on, or as they're going out of the services and just trying to understand how are we going to, alleviate this client from coming back into the Sobering Center or into a higher level of care? What is it that they actually do require out in the community that they're not currently receiving? And so our care navigators have been instrumental in that, which is basically, the ability to partner with CalOptima in that sense. So that's really truly we were here, but we just were able to enhance based on the community supports.
Great. Diana, any other questions from the Q&A?
Yeah, so I know we touched on this already, but certainly it seems important to a number of folks on the line. A little bit more about how this service fits into the continuum of care and different referral pathways. So we had some questions about coordination with justice, emergency departments, perhaps community paramedicine, getting a picture of what that looks like. How do people show up at the door, and what services are and are not available through sobering centers, and how that referral pathway is organized for things like medically assisted treatment and otherwise.
Yeah, so for the sobering centers, referrals come in through all areas, I guess, within Orange County. Law enforcement, as mentioned earlier, is one of our larger referral sources, along with self-referrals. A lot of times what we see is in the continuum of care of services, if somebody is if they're not sober, they're not eligible for care in that moment. And so being able to address that sobering component And then allowing that person to then be assessed, come down to a state where they can be assessed for services. And then the services are actually assessed appropriately. So for example, sometimes someone will come in and they will be under the influence of alcohol or drugs or both. And that might present as a mental health symptom where in fact it's sober, it's an alcohol or drug symptom. The beauty and design of the Be Well campus is we also have substance use services here on campus as well. They're then able to transition into this next level of care if they do in fact need substance use services as opposed to mental health services. But a lot of times if someone is coming in a referral and they are not sober, they might not be able to get the care they need if they present it at a clinic. Someone wouldn't be able to assess them and they would, have to refer to another source. So we're able to take them as their present state, get them into a state of ability to assess, and then transition them into these other services. Did that answer it?
Yeah, and another question, and I think this is top of mind for California stakeholders as well as nationally. Sobering centers often were a community resource, and specific billing for Medicaid services is relatively novel for sobering center services. Can you provide a picture of how that transition to actually doing that billing for Medicaid reimbursement went, and what was needed for your sobering center?
Yeah, so originally the sobering center was open. It's a voluntary service, and the Be Well campus will not turn away clients for ability to pay. So originally as we opened, I think our first client was, had no funding. They were not, they didn't have Medi-Cal, they were not insured. And so our team was able to determine, whether they met Medi-Cal, get them connected to Medi-Cal, and then in turn bill to that. With present day, the ability to serve people regardless of their payer status has been something that behind the scenes we've worked with, CalOptima, we've worked with other payer sources to number one, determine whether this was a service that they felt was needed for their members, and then also how we could determine that the pay for that service was something that they wanted in their package of services. And at this current state, we do have contracts with some insurance companies, but we are still working towards contracting with others. And one way that we were able to approach the Kaiser model was we were able to, we did a full site visit with Kaiser, just as we would with DHCS or any of the other entities, to allow them to see the services that are being provided, the scope of what's being provided for the clients, and to determine whether that was something that they were able to include in their package.
Thank you, Nicole. I'd like to acknowledge something that we haven't at this point in the conversation, but that especially California is struggling with an immense homelessness issue, and how that sometimes impacts different levels of care. So how did you determine capacity and what happens when you're full, and just overall structure when of the continuum of care, so that people keep moving through the process, coming in and also being discharged to the appropriate level of care? So I'll open that up to both Mia and Nicole.
I'll let you start, Nicole, and then I can also follow up just with some additional context.
Yeah, so thankfully, so part of the sobering center service, it's typically a 6 to 8 hour service. While it's marketed as 24 hours or less, typically someone only needs to be in service between 6 to 8 hours. So we technically have the ability to to treat up to like 3 persons per bed per day. The way we determined the amount of beds needed was partly, part of the licensing. So with licensing, we had to obviously apply for licensing and ensure that we didn't have too many beds for the space. We're on 60 acres, so we're not we're not a huge center, but we also had to, just consider those other factors. The other piece of it was ensuring that we had the funding and the staffing model appropriate to serve those clients. So being mindful of that as well. I think overall, there's not been too many days where we were so full that we had to turn people away. There have been days during COVID where we had like a COVID outbreak. And so, we had to shut down like 1 or 2 of the beds because we had to use them for isolation for people who were COVID positive. And there's been a little bit of challenge with that, just trying to address how do we accommodate for people that might come in with very an illness that might be easily contracted and disturb the rest of the room. But essentially we've been pretty good at not having been completely full that we had to turn people away. In the instances where we might have to turn someone away, which I honestly can't think of a day where we did turn someone away. In the instances where we might have to, we do have partnerships with other community partners. So we have like College Community Health, and they run a CSU. We have a CSU as well. So at times if we needed to adjust and that person, like we can determine, say this person came in and they were also in a crisis in mental health, then we could shift them over to the crisis unit and then fill our sobering. So depending on the client's needs too, because a lot of times they would come in where it's dual diagnosis and they have a mental health need and they're really medicating for that need, and the medication is, the alcohol or drugs. So we're able to kind of on a as needed basis and by client basis determine how to shift that.
It's great.
only thing- yeah.
Go ahead, Mia, sorry.
Yeah, the only thing that I would add is that, so as I mentioned earlier, we do have 2 sobering centers that we're contracted with. I know that our other sobering center, in terms of capacity, they generally run with lower numbers than Be Well. And I think primarily Be Well is so successful because of their relationships, the relationship that they have with the EDs, the relationships they have with the different correctional facilities, police officers. I mean, those are really, people know about Be Well. So like, oh, take this member to Be Well. Our other partner has not been as successful in marketing their services, and we're going to be working with them over this next year to try to help them make those efforts so that they can get some more individuals into their beds as well. So just wanted to kind of put that out there because I think for all of our community supports, being able to continuously market is really important. There are so many services that are available, social services, to our members that are out there. So we don't want to put the onus completely on, our providers or our different referral community-based organizations. It's about us making sure that we're making people aware that these are available, services are available to them, how to make referrals. And we know there's also a lot of turnover in direct service organizations. So again, really making sure that our marketing campaign, if you will, is ongoing, is something that we're very invested in.
Fantastic. This has been a great conversation. I think it's time to switch gears and talk a little bit about day habilitation services. So I'm going to turn it over to Mark to do that. And Nicole and Mia, if you have a chance to look in the Q&A and see if there are any questions we didn't answer that you can kind of answer live, that would be super. So over to you, Mark, and thanks very much.
Thank you, everyone.
Thanks, Melora. Great overview, Nicole. And I'm really glad to be with you today to talk about our approach on day habitation. And our program is quite different than Be Well's. And we're, I would say, not considered a traditional health service provider. So this was all new to us, but super exciting. So we have a few charts to go through here, a few slides, and then we'll have some time for questions. So if you could go ahead and advance to the first one. So our mission at Chrysalis is pretty simple. We help people prepare for a job search. We help them get a job, and we help them keep that job. What is not so simple is who we work with. We're working with folks that have experienced significant barriers to rejoining the workforce. They perhaps have been unhoused, they've been involved in the justice system, they may be in active recovery, or more likely, probably a combination of all of that. And if they were to walk into a traditional unemployment office or a work source center, the level of support they're going to get there just isn't going to quite meet it. Next slide, please. So this is a super busy slide, but it gives you a sense of the way we approach our work. We're focused on working with adults. Our average client is 40 years old, actually, and they've been in and out of systems for a long time. And actually, we find that they're usually pretty skeptical when they come to Chrysalis. They come to us voluntarily. No one is ordering them or mandating that they come to our program. And in fact, 60% of the folks that find us through referrals from friends, families, neighbors, others that have had success with our program. And at its core, what we're helping folks do is, as I mentioned earlier, prepare for that job search with job prep, resume, interview prep work. But really the core of what we're doing is deep trauma-informed case management services in treating each of the thousands of clients that we'll work with each year individually to figure out what's going on with them and what's getting in the way from them finding success. In most cases, if you were to, I'm in our downtown LA office today, and if I were to walk around and poll our case managers, hey, what are you doing today? What percentage of your time is related to a job search today? It'd be a pretty small number, because what most of our staff are doing is helping our clients deal with all the other stuff that is getting in the way, whether it's housing, transportation issues, interactions with their parole agent, health-related, physical and mental, all of that stuff. If it is not really, really solid, it reduces the odds that someone will successfully be able to get and keep a job. Let's go ahead to the next slide. So we're a Southern California-based organization. We have 6 centers in Southern California. We started in downtown LA. But we opened in Orange County 5 years ago, which is relevant for our relationship with CalOptima Health. But we also have operations in San Bernardino and Riverside counties, for those that are familiar with Southern California. Next slide. So this is from 2022, but last year we'll hit about 1,800 clients getting outside employment, and our average wage rate for those clients is about $18.80 for 2023, which is a couple bucks above minimum wage. And in a high cost of living place like California, that's not a living wage, but it's a heck of a lot better than minimum wage. And the way that we look at it is that it is getting our clients on a pathway that they design to reach the goals that are important for them. And really, at its core, I think we all know that a job is a means to an end, because what our clients are really coming to us for is for the opportunity to reconnect with their family, with their community, to have the respect and dignity that comes from a job. And as we all know, that relates to health. The number one thing I hear personally from our clients as to why they're interested in making money is so they can take care of their kids. Many of our clients, probably the majority of our clients, are non-custodial parents, and perhaps they've kind of given up on the opportunity to get custody of their kids back, but they want to play a role in their life. They want to be able to help support them, and having a job is obviously very important in order to be able to do that. Next slide. Another aspect of our program that is a little bit different from the traditional workforce development approach is our social enterprises. We own and operate 4 businesses that are designed to provide transitional jobs for our clients. when someone presents to us and meets with a case manager and they figure out that, hey, if this person were to just go down to Starbucks or Whole Foods or to a local warehouse, their odds of landing that job are pretty slim. It could be because of the criminal background issue, the resume is a blank sheet of paper. Perhaps they have what we call a professionalism deficit. They won't interview particularly well. Those are folks that are ideal to work for us for up to a year, and our clients pick up meaningful skills. But more importantly, they just learn what it's like to go to work every day and work as part of a team and respond to supervision and understand that no call, no shows are really bad. All of this stuff that many of us probably have been doing since we were 16 or 17 years old. For many of our clients, they've never been in traditional structured jobs. And so this element of programming is really important for us. Every Friday's payday. Last Friday, I think we had 750 of our clients that got paychecks $18 and above. So it's a big business for us, but really the reason we're doing it is a very specific programmatic intervention that is a necessary step before someone can then go get what we call an outside job, meaning not on our payroll. Next slide, please. So let's talk about CalAIM and specifically community supports. Mia was speaking earlier about the definition of DAHAB, and the way we got involved in this is Mia and her colleagues, Danielle and Kelly, we had worked together previously when they were in the provider space. And we were partners in terms of providing staffing services to the agency that they worked at. And so there was a pre-existing knowledge of what we did and the value that we provided. And we were approached by CalOptima to say, hey, there's this new thing, you might be interested. And of course, I was a bit skeptical about it because I wasn't familiar with it and we're not traditionally in the space. But when you start looking at the elements that DAHAB is really designed to help with, well, of course, employment is really important with that. Next slide. And we've also done through our own studies and a third-party evaluation that was done a few years ago of our program. Employment is clearly a social determinant of health. And in fact, as we've tracked our clients over time, their physical and mental health improves just by the virtue of having regular work. As we dug into this relationship and understood it more, we learned that our case management approach, as well as working in the social enterprises, is in fact a billable service. And so last year, as of the time this slide was put together right before the holidays, we had about 200 approved authorizations. It's increased since then. And in fact, I just heard yesterday, we have about 135 clients that are currently on billing. And for us, that's about $10,000 a month just in Orange County alone. That's significant for our agency and our ability to go deeper with our clients. And we're looking forward to expanding this in LA County over time. Next slide. Now, this hasn't been easy for us since we were new to Medi-Cal, just figuring out the contracts, how to bill, how to get authorizations, the language, how to tie that into the case management system that we use. That was all new. And for those of you that do this every day, I'm sure you're probably familiar with the challenges at times. And to be honest, as a leader in an organization, I was asking my team to do something new, different, and extra that perhaps, let's just say they didn't appreciate at the time. And it took us a while to build the support internally to be able to get this to the point that it is now. I think we've gotten over those humps. We've learned how to administer this and are having great success. And the team is now enthusiastic about being able to bring this level of service and partnership to the clients that we serve that are qualified for this. Another thing that's unique about our relationship with CalOptima Health is they are the only Medi-Cal provider in Orange County. And so it was a very close relationship, as Mia was talking about earlier, about they're not just there to say approved or disapproved. They're there to help us and coach us through just getting this thing started. As we look to do this in other parts of our service area in Southern California, it's not going to be so easy because in LA County alone, there are 5 qualified providers. So how we structure that and how we begin to have those conversations and adapt to their own unique administrative procedures is going to be a bit of a challenge for us, but we're up for it because we see the potential of it. That's all that I've got for a prepared presentation. So happy to enjoy a dialogue.
Thanks so much, Mark. It's really great to understand this. Could you talk a little bit about how, in the context of CalAIM, people come in for services? Are you finding that it's the same clients? Are you finding that you're, getting referrals from ECM providers or from recuperative care? Like, what's the, how, if at all, has CalAIM changed kind of who you see and how you get connected to clients?
Well, it turns out that most of the clients that we see are either already enrolled in Medi-Cal or they are eligible, in which case we can help them enroll if they are not already. So one of the, I think, aha moments for us was that, first of all, our clients are eligible to receive these services. So why aren't we making them available? Why aren't we referring them to other agencies that could provide deeper services? So it was a great educational opportunity for us. But it was not a situation where we had to go looking for folks to serve. They were already qualified. We just didn't know it at the time.
That's super helpful. And how do you work with the other elements of CalAIM? So with an ECM provider or, with community supports like housing navigation or things like that?
Yeah, it's, our work, all of the work that we do, we can't do it in a vacuum. We've got to have partnerships. And so each of our offices has its own network of service providers that do things that we just aren't good at or that we've chosen not to do. We know we're really good at jobs and the things that are related to that, but we don't do sobering centers. We don't do recovery work. And in fact, Be Well is co-located with us in a building, in our Anaheim building. They're right down the hall from us. So the only way we can do our work is to have partners. And one of the benefits of this program for us in Orange County, as I mentioned, we've only been there 5 years. And in the context of our agency, we've been around 40 years. So Anaheim for us, we're the new kid on the block. And so this has given us credibility to then develop deeper relationships with other service providers that either we didn't know about or we didn't have relationships with, or maybe we wanted to, but we didn't have anything to offer. Well, now we actually have a reason to talk. We have a reason to collaborate. So that in and of itself for us has been kind of like a good housekeeping seal of approval as we're trying to expand and grow our services in Orange County.
Mia, you looked like you were about to say something. Well, I have a question for you.
Sorry.
As you think about your network of DayHab, do you, and you think about kind of, individual members, the kind of scope of DayHab that you provided isn't just about jobs, it's about other things too. Do you kind of use your network differently depending on the needs of the member, or how do you think about that?
Yeah, 100%. So, and I think that goes for all of our community support. So finding the member match is really important to us. And so, and again, that's yes, for day habilitation, for housing navigation, for any of our services. So when a referral comes into CalOptima Health, we look at the needs. If there was an assessment done for certain services, there needs to be an assessment done before, or that comes with the referral. But then we look at their specific needs. We even look at specific locations, because for our counties, there are, South County services look very different than North County services. And so really understanding where we feel that member can best be served is a part of making sure that match, we're making the best match for the member. And of course, this is member choice. So a member may come back to us and be like, hey, I'm having a hard time connecting with my provider at XYZ agency. And we'll say, okay, well, let's look and see what other agency has capacity, what other agency you might want to be matched with. But that's, to me and to us, is a very important part of our work, because I think that's what makes these services successful.
And I used to work in managed care, and I think under the construct of in lieu of services, some plans are thinking about the cost effectiveness of these services. And I know that CMS has blessed it, DHCS has blessed it, but I'm kind of curious about with DayHab in particular, how do you have this conversation with your CFO?
Yeah, honestly, we haven't really had to have this conversation with our CFO yet. Our leadership has been extremely, extremely supportive. I mean, before we even started in terms of being hired here, it was like, we're doing the 14 community supports. It's not a question. This is what we're doing. Everybody on board. And so, yes, to your point, DHCS is like, we've already, these are cost effective. We don't necessarily encourage looking, at the ROI deeper than what we've already stated. And so for us at this point in time, 2024 is really going to be focused on looking at the quality of care that we're providing and really getting a deeper understanding of how these services are connected. And I think part of that will be looking at cost effectiveness to a certain extent and looking at what outcomes our members are seeing when they go to DayHab. If they're an unhoused member, they go through maybe housing navigation, they get a deposit, they go into housing tenancy. Once they're in tenancy, they then get connected to day habilitation services. What do the outcomes look for? What outcomes are we seeing for a member that utilizes all those services versus a member who maybe only utilizes one of those services without the other? So kind of looking at our outcomes from that perspective is really going to be a big focus for us in 2020.
That's great. And how do you think about kind of making partnerships between providers? Mark described the co-location and other things, but, are you mostly relying on kind of existing kind of relationships and partnerships between your network of community supports and ECM providers? Or are you kind of actively encouraging folks to, get to know one another, refer to one another, things like that?
Yeah, no, I would say both. Again, I think I mentioned earlier, we do have monthly all provider meetings. We like to highlight at least one of our providers during that meeting so that they can talk about their services. And also, I think it's just an opportunity for sharing best practices. We're learning from each other. But really, it's also about building relationships, helping our organizations come together and have that opportunity at least once a month to be talking to each other. We are actually next month going to be having our first all provider convening. That's something that we're very excited about. We're hoping to then do that annually. Again, giving our providers an opportunity to come together. For us, it's really, showing our gratitude for all the services and everything that they're doing for our members. But again, I think that idea of socializing, coming together, especially as we're sort of, well, we're not out of the pandemic, but we're coming together in person again. Really taking that opportunity for us is going to be something we also focus on for the next couple of years.
And there was a question, it was actually about sobering centers, but I think it applies for all community supports, including DayHab, and I'll kind of start with Mia, but would love to hear from Mark and maybe Nicole too. But, one of the kind of elements of CalAIM and of these services are kind of closed loop referral systems, so that, different providers who are coming together to support people with complex needs kind of know what's going on, know, when a patient or member is actually connected to services. How is that working in Orange County?
Yeah, so for our CalAIM services, we actually have our own proprietary referral system. It's called CalOptima Connect. All of the providers that are contracted for community supports as well as ECM have access to that service, and they can see what other services their members are utilizing from the CalAIM perspective. Now, that is somewhat limited because it is only for community supports and ECM providers. We are looking at integrating with another closed loop referral system in 2024 and probably even leading into 2025. So that's definitely on our radar and is something that we will be engaging in. But at this point in time, we utilize the CalOptima Connect system just for our internal community supports and ECM provision of services.
And for clients who are at a higher level of care service, so CalOptima supports the mild to semi-moderate level of care for membership. The county mental health plan attends to the higher level of care service needs for our clients. So our provider for Sobering Center is connected with the county mental health electronic health record system. And so each time a member comes in, and they're checked for their Medi-Cal eligibility and checked to see if they're open in other services. They also have access to see whether they're open in the mental health plan services. And so they can then be reconnected with or linked with their current provider, or reestablish a connection or linkage to a provider. Perhaps they were seeing someone and they fell off the system, and they need to reconnect with that. So we're able to link them through that method.
From our perspective, the more we know about a client, the better we can serve them, right? So understanding these interconnections is super important, and we wouldn't otherwise know this unless a client voluntarily told us about it. So this helps. I do want to go back just for a second to the partnership thing to give you an example of how it works and how it's benefited our clients and our agencies. So one of the providers in Orange County that is already part of the CalOptima Health Network is the Illumination Foundation. They're a housing provider. They do transitional housing, they do recuperative care. And we had a light touch relationship with them. But because we ended up being tied together through this program, we now have a very strong two-way referral system. One, for housing opportunities that our clients can take advantage of, but also we're in the jobs business, right? Illumination Foundation needs talent. We have, I think we're up to 30 of our clients have been hired by Illumination Foundation to serve open positions, the staff open positions that they have. So would that have happened without this relationship? I don't know, maybe our business development folks would have been good enough to do it, but I doubt it. So I think that's an example of the kinds of ancillary things that can start happening because these relationships end up being organic, and trust is so important. I think, Mia, you were hitting on this earlier. Once you have a business partner that you trust, you start thinking about other ways you can work together. And this has been a great way to get that going.
And one more question on operations. We're no longer out of the pandemic in terms of continuous eligibility, and so redeterminations are now a thing. It's probably less relevant for sobering centers, but I'm kind of curious for Mark and for Mia, how you are kind of partnering to help people maintain eligibility.
I'm going to start, Mark, and then I can.
No, I was going to say you start.
Okay. Yeah, that's a great question. Part of what we're doing is, and this is also internally, our community relations department is also, we're looking at opportunities to bring them in to help to communicate what we're doing internally as a MCP, and also what we're doing in the community. So giving them a platform to communicate that to all of our providers so that they are aware of what we're doing is incredibly important. And we utilize our all provider meetings to be able to give them that platform. The other thing is, and this just comes up operationally in different ways. And so on CalOptima Connect, because I will say this, and I think it's important for other providers to know, some members may fall out of eligibility. And so ensuring that we are telling our providers to continuously check eligibility, but we're also continuously working with our vendor for CalOptima Connect to put little, what we would call like little banners or things so that we can trigger something for the provider to then check eligibility if a member's eligibility has changed. Because what can happen is, I'm a provider, somebody comes in, they're referred, I think that they're eligible, I'm providing service, and then something happens. And I don't necessarily check. I continue to provide services, submit a claim, and it's rejected. And that's a difficult position to be in. Again, especially because we've contracted with a lot of community-based organizations. Again, as I mentioned, that cash flow could be an issue. And so making sure that we're having those conversations, and that's something that's actually come up to us directly from providers. So taking that information and then from our perspective, doing something about it. Like talking, again, as I mentioned, that came up from two specific providers, and we're like, okay, what can we do? We started having conversations with our vendor for CalOptima Connect to make something happen. So just kind of I think that's a good example of the partnership and really taking action when our providers do mention things to us.
And one final question, and why don't we start with the providers and then kind of close out with CalOptima Health. But part of the reason that we're doing this series is to kind of help others learn from your example. So what advice, like what 3 things would you kind of advise other kind of folks entering the space or entering these types of partnerships? Mark, I'll start with you if that's okay.
Let's see, 3 things. One is take a little risk. You know, our work is complicated, and the folks that we serve are taking a risk just by walking in our doors every day. So as an organization, as we've grown, I think we've become a little more risk averse. But when this opportunity first came up, it seemed a little too good to be true. And maybe I mean, it is too good, but it is true also. We wouldn't have figured that out if we hadn't taken a risk and thought about a non-traditional way to provide services to the folks that we're already serving anyway. So that's the first thing. I think the other is don't underestimate the investment in administrative infrastructure it takes to do this and to do it well. We're just finishing our budgeting process for this year that we're in, and we're adding some additional administrative support because we think this program has the opportunity to grow significantly, but I also don't want to put blinders on and pretend it doesn't take work. It is a administrative intensive effort. Let's just make sure that we support it. And I guess the last thing is leverage the opportunities that are being created with partners in the network, folks that we may think we know, but probably don't know well enough or don't know the breadth of everything they can help with. This is a great opportunity to build that network.
Thanks, Nicole, over to you. Same question.
Yeah, I love what Mark said about the administrative intensity of it. There is a lot of background work that happens, and I think one of the important things is taking that risk and putting yourself in the shoes of the client. So if you model it after, if I'm a client and I am really, in need of, all the continuum of care of services, I'm a whole person, and a lot of times the bureaucracy doesn't address that, right? So we have to go to one place for one thing, one for the other, and they're continually being asked the same question over and over again. So Be Well, we always put ourselves in the shoe of the client, and just to align with what would that best service look like, and how can we kind of blur the lines so that it's not something that's a challenge for them. The other thing is having leadership at the table. So we were very instrumental. Be Well started as just a momentum of partners in the community that said we need to address these gaps in care, and how can we do that? And so I did mention we have philanthropy at the table. We have, grants, we have different funding sources, and everyone's at the table to say, how can we do things different and do things well? And I think that's like really important message to take home, and provide for the infrastructure to enable that to happen, right? Because you don't want a great idea to fizzle out because you don't have the resources and the infrastructure to be able to sustain it. The worst thing we want to see is that some great program disappears because we haven't thought thoroughly through sustaining that infrastructure to carry it forward.
Thanks so much. And Mia, what about advice for other plans?
Yeah, I love what Mark and Nicole said. I think for plans is to think about being flexible. I think that we have been as an MCP extremely flexible in the way that we have opted to implement really all things CalAIM. And so putting the member at the center of making all the decisions that we make, whether that's what providers we partner with or how we decide our policy guidelines, to us, that is extremely, extremely important. And I think that also has helped us make a lot of these partnerships. I think the risk thing of Mark and Nicole, like that to me is such a big point, because I can tell you there are organizations in Orange County that I have been wanting to partner with and bring on and contract with for a year. And we've had conversations. I'm like, I'm gonna call them again. I'm gonna see if they're ready. I'm gonna try to convince them. And there's just something that I think it's just them being risk adverse, but I'm confident that we will bring them on. And I think part of that is also, historically, community supports is not something, these types of services is not something that MCPs have experience implementing. So this is really changing the game of how we as MCPs operate. We're now funders. We're now like helping to be service operators. So I'm hoping that MCPs can kind of change their perspective on how they partner and how they operate within the continuum of care. But I would just echo also what Mark and Nicole said. I think, you know, as really cherished providers, they've got a lot of insight in terms of, you know, what it takes to make these partnerships happen. And we're extremely, extremely grateful for all of our partners who have helped to make CalAIM Health successful in implementing all 14 of our CalAIM based plans.
Thanks so much. If we can bring the slides back up. You know, we want to let you know this is the first in a series. We're kind of hoping to go deep on some of the services around supporting people with functional impairments who might otherwise be in a nursing home, the services they need to stay in the community, and kind of, you know, go deep in other parts of the state to understand kind of where the bright spots are and how things are evolving and what's going on with the partnerships. So you can sign up with CHCS to learn more and get a heads up when our next webinar gets scheduled. But really just wanted to thank our amazing set of panelists for making the time to do this. So new in the new year. It's a kind of great way to kick things off. And, you know, I hope that when the 2023 report comes out, we'll see a lot more utilization of these really, really vital and important services. So thanks very much, everybody. And, you know, looking forward to continuing to work together on CalAIM implementation to get to more person-centered care.
Thank you.
Thank you, everyone.